Good morning. Please settle down, everyone. Good morning and welcome back. Good morning and welcome back, everyone. Good morning and welcome back, everyone. We are delighted to have you with us today of this academic journey, day 3, a day dedicated to bridging theory with clinical practice. We hope you are ready for an engaging and enriching experience as we continue to explore the sleep of science with a practical lens. Let's begin. Today's session will focus on various sleep related areas including sleep hygiene, sleep related disorders, and polysomnography, one of the most essential tools in sleep diagnostics. Through hands on practical exposure, we'll gain a deeper understanding of sleep patterns, physiological signals, and their interpretation in real world clinical scenarios. It is our pleasure to welcome you to this engaging day of insightful learning led by none other than Dr. Christina Franz ma'am and Professor Zubia Wakar ma'am, experts in sleep physiotherapy. Today's session promised to enrich our understanding of sleep disorders and their practical management. Let's begin with the first lecture of the day, led by Professor Zubia Wakar ma'am. In this lecture, she will delve into the concepts of sleep health and sleep hygiene, which form the concepts of sleep preventive strategies for sleep disturbances. Let's welcome ma'am with a big round of applause.
Okay, good morning everyone. I hope you all slept well yesterday. No? Who didn't sleep well yesterday? Oh, new place, I can understand. Yes. And the last one, then why did it, तुम्हें क्या हुआ? अच्छा. The social activity was, so social life was basically more engaging. What happened to you? Achha, the baby was traveling. Okay. Anyone else? The rest everybody slept well. How has been your learning till now? Did you learn anything new in the 2 days that we've been here? Yes? Do you think it was engaging enough? Okay. So for today's lecture, this was supposed to be done at 11 o'clock yesterday, but I shifted it as I told you because we were talking about assessment in yesterday's class. I wanted to finish with all aspects of assessment and then proceed further. So we're going to be talking about sleep and then sleep hygiene. This will not be a very long lecture, but of course it is a more theoretical lecture. So I would want you not to sleep. Okay, I will try my best not to put you to sleep, but I would definitely want you all to find that sleep which might come in because it's very, very theoretical in nature. But the purpose of this lecture is, even though I know it is not a very, you can say, exciting as other things are, is because this is one of the most important aspects that you would be taking care of when you talk about advocacy. Okay, and as I told you yesterday also, that I want you all to be the spokesperson for the field. You all need to go back to your places and make small niche areas for yourself where you can function as sleep physiotherapists or sleep experts or sleep rehab experts. To do that, you first need a background as to what we are talking about and how will we proceed from there and what all areas are of important concern to us. So the lecture today would be divided into two parts. The first part, we will be talking about sleep health. So we basically talk about the differences in the sleep health, and how would you want to divide the sleep health into, what do you understand by sleep health, and what are the problems with the WHO definition of health. That also we're going to delve into a little bit. And then the second part would be about sleep hygiene. Sleep hygiene, again, as Christina must have spoken to you yesterday, is one of the very important strategies which is used as a management strategy, especially when you are dealing with young adults, when you're dealing with people who do not have a diagnosed medical or clinical sleep disorder. In those conditions, sleep hygiene modifications become almost essential. So just preparing a handout, handing it over to your patients would be a great idea, and it is definitely going to bring you changes there also. Okay. So first of all, sleep health, as I said, there are certain questions which would come to your mind after you have attended the course or after 2 days. That first is, we have been talking about sleep. So what is the term called sleep health? Why is it important to understand? Now, when you put in the keywords of sleep and health in Google, you would get a number of articles. N number of articles would be there. But the moment you start screening them, you would realize that they're talking about sleep and health. Okay, so when they talk about sleep and health, what they basically mean is what is the relationship between sleep and health, which is a different area from which I want you to focus on today. Today we are talking about sleep health as a single component unit of sleep health, which basically means a component of health paradigm in understanding sleep. So first thing, as I said, is written here, is sleep health important? In my class, in my first class, when we were talking about physiotherapists and sleep, I showed you a study which was conducted in US, a massive study conducted in 2015, which tried to focus on the various sleep disorders in the general population, correlation with pain, what are the factors which are correlating, and how would pain management be better if sleep was managed accordingly. So from that time onwards, or rather before that onwards, there has been a movement where we are trying to define sleep health, and is it necessary, is it really necessary to associate sleep with only negativity? And that is exactly what we have been also doing since the past 2 days. We are trying to tell you that if sleep is not proper, then what is happening? So we are talking about sleep in a very negative connotation instead of it being a positive connotation. And in today's time, we're talking more of well-being is becoming a more important term. So wherever you go, whether you want to go to the gymnasium or you want to go to a place where you can practice, or when you're dealing with your patients, young adults, students, all these community lectures, all these things, when we're talking about, what are we actually focusing on is more between a positive relationship instead of being a negative relationship. So just to develop an idea where sleep health is also a component is the purpose. Secondly, can we define sleep health? Definition of health took almost 2000 years for health to be defined the way we are looking at it right now. And even now, there are people who are not very happy with the definition of health. Now, you're talking about about a condition, about, I would say, a paradigm which is almost non-existent. A very, very, very small group of professionals are the one who are actually working in this particular area. So when you're talking about it in that way, then can you actually define sleep health? Because the moment you talk about defining a thing, you are trying to understand the various aspects, factors, and everything has to be covered within that one definition. Otherwise, what will happen? There are certain aspects, if they are missed on, it would fail to become a part of that particular definition. As a result of it, they would fail to become a part of that entire structure that you were talking about. So defining a thing is one of the most difficult tasks. So is the sleep health definition important? That is what we are trying to answer. Thirdly, can we measure it? Every other aspect needs to be measured. Everything needs to be measured. As I said, in today's time, you need a subjective as well as objective examination. Most of you would have done or are in the process of doing some studies. Your teachers must have told you, or you must have decided that there are certain aspects that you want to cover. So there would be some objective measures that you've taken, there would be some subjective measures that you've taken. No study in today's time is completed only on subjective measures. You would always need to substantiate it by objective measures. So having said that, that would also mean that whatever we are talking about should be measurable. So if I am trying to bring up a new concept in front of you, there should also be a way to measure that concept. Hence, sleep health needs to be measurable. Then we talk about, does it matter if we do? Why would it matter? I want it from you. Why do you think sleep health should matter? Why should we define it? Why should it matter? Okay, so that we can understand what is good and what is not. Anything else? Sorry? Okay, the patient recovery is going to be better. Quality of life is going to be better. Anything else? Okay, okay. Okay, it's one of the confounding factors. It will help in management. It will be helping in decreasing the predisposition to some conditions. So basically what we are trying to tell you here is, or what you all are trying to tell me here is, again, something which is having with a negative connotation. We are all talking about a negative relationship in between. So if the sleep is poor, what is going to happen? That is what our focus has become. That is why it becomes important for you to assess sleep even for normals also. Okay, that is why we are talking about sleep health. That is why measuring it is becoming important. So isn't sleep health just the opposite of sleep problems or sleep deficiency? That is the natural thing that should be coming to our minds the moment you look at whatever we have spoken about till now in these last 5 minutes. So how is it different? Just absence of disease? But is that the way WHO has defined health? No. Health is not absence of disease. So similarly, sleep health can also not be absence of sleep disorder. Okay. So these are the basic questions where we are going to delve into. The first thing, let's talk about why. Sleep health is not simply an absence of a sleep disorder. As health is not simply an absence of disease, similarly, sleep health also is not an absence of a disorder. Now, this entire concept of sleep health came from the same people, the group which was working in Pittsburgh. Busey et al. Are the ones who came up with the entire idea of sleep health, and they worked on the idea that why sleep health is important and why is it essential and why should it be defined. So they came up with one of the articles in 2012 or 14, around that time, where they spoke about the concept of sleep health, and it came out as an idea where they talked about all these questions that I'm talking about right now, and from there they picked it up, and then you came up the National Sleep Foundation and American Sleep Association. They themselves came up with position statements regarding the same, and then eventually after that what happened was that there was an area that was created where a lot of policy decisions were made, or rather proposed. I would not say made, I would say a number of policy decisions were proposed to consider sleep health as one of the paradigms. Okay, so sleep health, that is why, is not supposed to be only an absence of disease. Then it should be quantified degree within normal range. So what we are saying is, yesterday also we spoke about that the number of hours cannot be 5, 6, 4, 3. It is talking about a range where you say either 6 to 8 or you talk about 7 to 9. Based on the age groups, a little bit of variation is there, and based on authors also there is some amount of variation which is there. Some authors talk about 6 to 8, whereas some authors talk about 7 to 9 hours. Okay. Now, just if I say according to the duration. So I asked you in the morning that did you all sleep well? Only 3 of them said they did not sleep well. So what I understood was that most of you slept well because you maybe completed the mandatory part of or the number of hours that you wanted to sleep for, and you were okay after that. But you did not delve into the idea that tomorrow morning there was a stress of getting up in the morning, even though it was a Sunday. Right? Some of you would have wanted to complete your sleep debts on Sunday, but could not do that. So that stress was there in the back of the mind. That is why maybe you were able to get up on time, and you knew the first lecture is mine and I would not allow you to come later. So you made sure that you are here on time. As compared to yesterday, I saw all of you were here on time today at 9:30. So that was an additional stress which might have helped you in waking up in the morning. Okay, so that is how a definition would go. That is how things would be defined, that it is not only the duration which is going to make a change there. There are other things also which are going to be associated with it. So the degree of normal is going to vary. So when we say the degree of normal is going to vary, that basically means not only by the quantity which we are talking about again and again, but also of the quality that you want to talk about. So it is also the quality which is going to be talked about. So quantifying the degrees become important. Whenever you talk about health, the quantifying the degrees is going to become important. Just give me a minute. Okay. So provides concrete targets for health promotion and prevention activities. See, when the definition of health was given by WHO, what did they do after that? They define what is normal. And then the second step was position statement which came up from different organizations. Spiritual well-being became important. The psychological well-being became important. Physical well-being became important. Well-being became a buzzword. Quality of life became a buzzword. These were not the terms earlier. If you look at the articles which were published in, say, 1930s, 1920s, quality of life was not there. It was non-existent. You would be seeing quality of life more in late 80s, you can say early 70s, late 80s, where things like that started becoming important because the focus was changing from disease oriented picture to a well-being oriented picture. That is how the change was taking place. So providing concrete targets as to health promotion and prevention activities, it means that we need, okay, I tell you that you have to sleep well. Next, what? How are you going to achieve that? That strategy also needs to be given. So that strategy is what is going to be coming from the definitions which are going to be there and eventual changes which are going to be there. Then broader agendas such as improving population health. Whenever you talk about a paradigm, whenever you talk about a concept, you need to be talking about the basic population whom you are going to deal with. For example, if you talk about hypertension, you have to focus on obesity along with hypertension. Obesity might not be the only factor controlling hypertension, but you cannot talk about hypertension without talking about obesity. Similarly, when you're talking about sleep health, you want to bring about a change. The basic population which is going to be affected needs to be targeted. So how is that going to be done? Because it is a variation which is going to be age-wise, the things which are being proposed should also be age-wise. So you would be coming up with strategies for school-going children separately, strategies for adolescents are going to be separate, strategies for young adults are going to be separate, for older individuals is going to be separate. Then only you can focus about increasing their quality of sleep health, because you know that the basic things are going to be different in all the categories. For example, blood pressure, when you talk about, you know it is 120 by 80. You know that I'm already aware that 120 by 80 is a normal blood pressure. But if someone with 80 years old comes and is not having 120 by 80, do you think it is pathological? No, you know that there is bound to be some changes. So even though your 120 by 80 is normal, it might be okay for an adult, for a geriatric patient to be having a little slightly higher up on the upper margins there. So that is how the differences are going to be there. That is why it is important that population health needs to be improved and population health needs to be focused. So the strategies developed has to be for the basic populations that we are talking about. So having said that, I would also like to encourage you to work on normal strategies more as compared to the pathological strategies when you're working on sleep. Then examining the entire range of sleep health is useful for sleep research. Funding is a problem. Everybody is aware. Okay, one of the basic problems that you see in research is funding. You have very good articles available with you, but you're not able to publish them because you don't have the APCs to publish them. Right? People who are working in research are very, very familiar with it. The funding has been decreased all over the world. It is not only in India. In US also, Trump has decreased the funding by almost 40%. So you are looking at changes in the funding patterns throughout. These are the, whenever you talk about well-being, that means you're talking about a drug category which is going to deal with well-being. What is that category? Things like melatonin. Right? Things like melatonin. You talk about multivitamins, you talk about calciums, you talk about your various other supplements which are being given. Ayurveda is coming up with its own supplements. So everybody is coming up with their own supplements. So they are the ones which are talking about so-called normals. Right? The moment but that also means the largest chunk of the pharmacological industry is pharma. You are telling them not to use those drugs. You don't want the people to be using that drug. So what you are basically doing is you are going against the pharma companies. So that funding is not there anymore then. So a lot of funding happens because of the pharma companies. So you are decreasing on that funding, right? So then what is the other option available? The other option available now is that you start working on normals more so that you are able to come up with normative data more, even though the funding is lesser. You need to be developing strategies by which you are able to talk about basics more than only pathological. You will be able to identify, you cannot identify a higher or a lower, but you remember when the time diabetes values came up, there were people who were non-diabetic and the next day morning after the normal values came up, there were people who were suddenly diabetic. The people who are in cardiopulmonary would be knowing that there's a lot of critique happening around those values of insulin, that the people, that it was basically done by the pharma companies, those levels are not required, and a lot of pharma companies, they had built up drugs which they wanted to be utilized. That's why large populations were converted into diabetics just overnight. But that also tells you that you have a data, or rather you have a value available with which you can compare things. Similarly, in sleep health also, it is easy to say 7 to 8 hours. It is easy to say non-restorative sleep. But what do you mean by non-restorative? You don't know. When I say quality, even I don't know what is quality. I can say slow wave sleep. I can say stage N2 and N3 is quality. But there is no confirmatory data which is telling you that this kind of a wave pattern is normal and this is good quality. I don't have that data available right now. So till the time that clarity is not there, you will not be able to function on pathology much. Till now, how do we work on pathology is what by a hypnogram, what Dr. Christina showed you yesterday. That is, it actually going into N2 or N3? That is what the hypnogram is telling you. It is not talking about the number of pattern changes which are there, the number of changes which are happening there. Those things are not touched upon. Okay, so that is why the ranges of sleep health, you have to remember sleep research, that is why becomes important. Okay. Then let's talk about definitions first of all. You are familiar that WHO definition of sleep health is there, which talks about physical, mental, and spiritual, psychological well-being. Those definitions were given. There was a lot of hue and cry after that definition came up. Even though you all have grown up looking at that definition and appreciating that definition also, because you said mental health is being talked about and spiritual health is being talked about, and it is not only mere absence of disease. That is how we all looked at it when you are studying. Because the definition came, of course, long back, but when we all started studying, that definition was in place. So that is how we have come up with understanding the concept of health. But there were a lot of people who did not agree with that definition. I would suggest that you all go back home and read a little bit about the critiques of that definition. So first definition, critique of the definition talked about there was no definition of good. Good was not defined, because good was not only absence of diseases. Good was not further defined. Those kind of clarities were not given. Then again, there was no normative data developed for that. You said that a subject should be having, or a human being, or a healthy individual would be having a physical health, a mental health, and well-being. Well-being was not defined. Okay, at that particular time, well-being was not defined. So there was basically a shift in the paradigm which took place. That is why, again, as I said earlier, well-being became a focus area, and it was not merely absence of disease. So there were four major models which are actually existing right now to understand health. First is the medical model. So in medical model, what do you talk about? Absence of disease. That is a typical model that you would be looking at. 99% of the physicians are looking at it in that fashion. So when you go to the physician, his first idea would be to find out a disease or a disorder. It would not be to find out whether you are normal or not, or whether you are healthy or not, or whether you are lying within the normal ranges or not. The focus would be to find out whether there is a disease or a disorder or not. So that is the understanding of the basic medical model. I think we work on a similar manner. The moment a patient tells you that there is a pain in the shoulder, you would be thinking of things which would lead to that pain in the shoulder, and instead of trying to understand that maybe the patient didn't sleep well yesterday night. That would be last thing which would be coming in your examination, because there was nothing else available. Then you might be thinking, oh, maybe the patient slept on that in the night on that shoulder, that is why it is paining. So most of us are working on that same medical model. The second one would be based on the World Health Organization model, which is based on the definition that we spoke about, where well-being becomes important. But again, well-being is not very well defined, but it is also said that well-being and health are correlated with each other. If the well-being is more, the health is going to be better. If the well-being is poorer, the health is going to be poorer. This is the concept from which you came up with the term healthy aging. The buzzword healthy aging, which you see a lot of times everywhere, especially on the yoga day and everywhere, you're talking about healthy aging. So what is healthy aging? Basically, someone who's going to age, you are accepting that aging is a normal physiological process. That a process which is, if it is healthy in nature, it is going to be healthy aging. But if you look at it carefully, what else did you say? Healthy aging leads to no disease later on. That is what we're talking about when you're talking about in totality. So somewhere you also associated health with an absence of disease or disorder. It did not stop at healthy and well-being. It went on to justify that absence of diseases is going to be associated. The moment you say that, I personally have a problem with that, because healthy aging does not mean absence of disease. Even if you had a very, very extremely healthy lifestyle, is it necessary that you will not have NEOA or you will not have an LBA? No, it is not necessary. All your changes are going to be any lesser in a when you pick up a radiograph of a CSC is fine. It is not that case. Is every smoker having lung cancer? No. No, it is not there. So that means there is some other picture also into play instead of just developing a fashion by which we are able to explain things which are related to disease and disorder. So third definition was wellness or role model. Here it emphasizes on function integration of mind and body. So this system talks about them, absence of disease separate and a healthy lifestyle separate. This is separating out the two. And the last one is the environmental, which talks about body as a resilient mechanism. This is a good upcoming model, and if you read about it properly, you would be able to appreciate it. I think I like this model because it talks about the modification and adaptations which take place in the human body as a response to the environment. Like the vestigial organs over the time. They were essential earlier, they are not essential now, so they are not there, the body adapted itself. Okay, people who are near the equator are darker because melatonin production is more, they need to fight the UV rays, so they are of a darker skin color. The people from the colder regions they do not require that much melatonin, the skin color is lighter, but the moment they come to the areas where it is more hot, they are going to get a sunburn because that layer of protection is not there. So your body is trying to fight the adaptation strategies in itself. This concept where we are talking about the resilience of the human body or the human race per se by bringing about changes in the third or the adaptive model or the environmental model. Everybody okay till now? Am I too fast? No, I'm okay today? Okay. So these four models again is how the providers of healthcare in clinical practice, and I think most of us should be working in at least two models at a time. That is what my suggestion to you would be. Try to focus on at least two models at a time. You can pick and choose whichever you understand better, but to do that you should be able to read better. You should be able to read about each model, go back home, or afterwards, after the course gets over, put some time and energy on trying to understand the various models. It would help you in understanding in a broader concept as to, as physios, what are we working on. It will be easier for you to understand. And then once you've identified at least two models, then the advantage would be that you would be able to correlate them with your patients better. Your understandings might improve. Okay. So WHO, as I said, in 1948 adopted the definition that health is a state of complete physical, mental and social well-being and not merely the absence of disease. Another problem also here is the definition of the word complete. Is it possible to have a complete mental health and physical health and social well-being? That means everybody is unhealthy if you go by the WHO definition, because it talks about the word complete there, and complete is not defined anywhere. Okay, complete is not defined anywhere. So if you look at it more closely, if you try to find out more closely, you will be able to understand the flaw which is there. Okay. So sleep health, first of all, it's multidimensional. Why would it be multidimensional? Because sleep in itself is multidimensional. That is what we've been talking about since the past 2 days. One thing is not, when we are doing sleep studies, it is very difficult to control the covariates there. Even when you are talking about PSG, the people who worked on PSG, none of them are here right now. But when they are working on the PSG, there are so many covariates which need to be controlled. As I said yesterday, PSG is not a gold standard according to me because it's a new environment. Those two gentlemen there could not sleep very well because it's a new place. They're not comfortable in that place. So if it was a PSG lab, the same thing would have happened there. It's a new place, a new pillow, a new bed sheet. Everything is new there. It's a new side. I'm used to sleeping on the right side. I have to sleep on the left side. I'm used to having a bed partner. The bed partner is not there now in that particular lab. Right? So you're looking at, it is not something which can be recreated. That is why the concept of wireless PSG has become more common these days. But again, in a wireless PSG, I still need electrodes here. How can that be normal? That cannot be normal. No? I'm not talking about looking at EEG pattern to understand epilepsy. That is not there. When I'm talking about a PSG electrodes, I have to place electrodes on my head, which is not comfortable, definitely not comfortable. I mean, hats off to the people who have volunteered for the PhD studies in the night in our center and managed to sleep through the night. I don't think if you tell me to do that, I would be able to do that. I would not be able to sleep with electrodes over my head at all. I would get up so many times in the night, even if you have a acclimatization night before. So how we'd go about is that one night you have an acclimatization night and the second night is the study night. But even if you have had the acclimatization night, it is not possible. It is absolutely not possible. It's very, very uncomfortable. So that is why you would be needing, the moment I say that, that means there are other factors also which are going to play a role in that sleep. That is why sleep in itself is multi-dimensional. You had a heavy diet yesterday, you had heavy food, you might not be able to sleep very well. You became hungry in the night, very commonly seen with pregnant women. They would have fragmentation of the sleep because they would wake up early in the morning because they are hungry. So a lot of women, if you ask them, they would be having a box of cookies beside on their bedside, so that if they get hungry, they would be eating those cookies, having a glass of water, and they would go back to sleep. So that's why Christian also told you yesterday that waking up in the night is not a problem. It's about whether you are able to go back to sleep again is not is a problem, is there or not. Okay. Then so it's a multi-dimensional pattern of sleep and wakefulness. Why is the word wakefulness also talked about here is because that is what also you are trying to define. The moment I say non-restorative sleep, what does that mean? After waking up, I'm not feeling good. So wakefulness, the definition, actually if you look at it since 2 days, what are we saying? You need to sleep well to function better. That means your focus is on wakefulness. Your focus is not on the night which passed away. No one is talking about the night which passed away. You are talking about how productive you were the next day. So it is a productivity the next day which is also important. So individual, social and environmental demands. So social demand, someone went out yesterday. So the social demand was higher, you slept lesser. Then you are looking at individual changes for them. It was not their side, they were not comfortable, did not sleep well. Environmental demands, it is too cold, it is too hot. Christina is finding it difficult if the AC is off because it's too hot according to her. When you go down south, especially in a place like Mumbai, it becomes very difficult for us, especially Delhiites, because it is very humid there. Even though it is lesser hot, but it is very humid. So I need the air conditioner on every time when I am in Mumbai. I cannot survive without it. It becomes too difficult for me. Going out becomes very difficult. So social environmental demands play a role that promote physical, mental well-being. You're talking about both the aspects here. Okay. Good sleep health is characterized by subjective satisfaction. This is extremely important for you to understand here. It is subjective. That also means satisfaction cannot be defined. It is not measurable. I can tell you to mark it on a 100 mm line and tell me how satisfied were you with your sleep. In the scales also which we discussed yesterday, the satisfaction level was measured by the line which was there, a 100 mm line to mark how satisfied you were. But it is subjective. So as I said, someone might be satisfied with a good 5-hour sleep. Now the definition of good is going to vary, whereas someone who has slept for 10 hours also might not be feeling good about it. So it is subjective in nature. Then it talks about appropriate timing. Not 7 hours, not 8 hours. It is based on appropriate timing. Adequate duration. Duration means hours, timing means what time you're talking about. Okay? So you cannot tell me I'm sleeping at 2 o'clock in the night because I'm a night owl. You cannot say that, because that is absolutely against the circadian rhythm pattern. I think somewhere down the line we have understood the concept of owls and larks differently. Owls and larks does not mean they're going to be awake in the night and function during the day. It just meant that whether you were going to go to bed at 7 p.m. or it is going to be 10 p.m. or is it going to be 11 p.m. It does not mean it is going to be midnight. Okay. So an adequate duration, high efficiency. And what is efficiency? We talked about it is measured in PSQI, where you said for how much time you spend in bed and what time you actually go to sleep, multiplied by 100 would be giving you the percentage of efficiency. And sustained alertness during waking hours. What does that mean? Do you want to be awake, alert during waking hours? Yes. And at the same time, do you want to be drowsy during the waking hours? No, you don't want to be drowsy during the waking hours. If you sleep for 4 hours, will you be drowsy the next day? No, not necessarily. It depends upon the individual. Not a, it might depend on the time of the day also. When you, that's why ESS was there. So everybody is going to be having some amount of sleepiness during the day, which will be associated with the surroundings and environment and everything else. But otherwise, it is depends upon individual thing. So you want to be able to function the next day. So a good sleep health is characterized by subjective satisfaction, appropriate timing, adequate duration, high efficiency, and sustained alertness during waking hours. This is what we talked about, inferred from what is written on the top to a more concise thing when you look at the thing which is written below. It's a replication. It's an absolute replication from top, but I removed all the other jargon which was there and I concised it for you. I want you to just read through the second definition and see if there is any aspect of it which you want more clarification about. Okay? Everybody okay with it? Okay, then let's proceed further. Now, the dimensions. So, sleep and wakefulness, they are endogenous to each other. They are recurring and they are behavioral. Um, when you say a recurring pattern, the recurring pattern can be an afternoon nap also for some people. Especially if you look at adults, at elderly, they would want a small nap in the afternoon for them to be able to function post evening. A lot of housewives will also be doing that, but of course working people, we don't have that luxury. But I would love to have an afternoon nap for a short duration of time. So on a weekend when I'm home, I would definitely want to do that. So it's a recurring pattern which is behavioral in nature. That is what one needs to understand. So it is not only recurring. What is important is the word. It is behavioral. So that means, if as the Vice Chancellor sir was talking about in his lecture, that his mother was used to sleep after Maghrib. So for Maghrib basically means when the sun sets. And in earlier times also, in India also, even now if you go to villages, if it is a proper village where people are not so much exposed to the social media and all that, in those areas you would find people roughly going to sleep after Isha prayer. That would be around 8, 8:15, 8:30 around, usually in most of the times. So they would there have their dinner after Maghrib, and after Isha they would go to sleep. And they would be up and awake in Fajr. I think 99% of us who actually wake up in Fajr, Fajr is at the earliest prayer that we have in the morning. That is around 4:30, 4, based on the timing of the season that you're looking at. So we would get up in the morning, pray and go back to sleep again. Most of us. There would be some nice people who would get up at that time and do their work and are active at that time. Other than Ramzan, we get up in the morning and we sleep again. Okay, so but that is not how it was supposed to be every time, right? So that is why what we are saying here, it's a more of a behavioral pattern. We have trained our bodies like that. The circadian rhythm was not made like that. The circadian rhythm is totally and completely associated with the sunset and the sunrise timings, which is related, basically trying to tell you about the exposure to the light, not the blue light, the natural light that you're talking about. So the melatonin was secreted in the body in response to the presence of our absence of sunlight, not the blue light that we are exposed to much more these days. So it becomes behavioral, and it reflects coordinated changes in dynamic functional organization of the brain. I would suggest that you go through Ganong and have a look at the sleep chapter there. It explains about sleep physiology beautifully. One of the lovely explanations. And Guyton is another book which you can also have a look at. Other than that, any good book by maybe Demented and all that, if you pick up about sleep, the initial chapters would always be about sleep. And we have already shared some neurobiology articles with you already, I think in the handout which is given to you. So neurobiology of the sleep becomes important, and it is important to understand even though we don't know it completely. But if you look at the complete picture of sleep, we don't know it completely. But neurobiology is one area which is, I would say, fairly well defined, fairly described pretty well. One area where a lot of work has already been done. So in neurobiology, you will be able to understand that there is a functional organization, that one thing leads to another. For example, core body temperature needs to go down, peripheral body temperature needs to go down. You are looking at a change in the sympathetic changes which are going to take place. There are certain parasympathetic changes which are going to take place. So step by step things will happen and your eyelids are going to droop. So there is a process associated along with it. Okay. So that is how the brain, that is the brain control part that we're talking about. So as a psychologist would say, the brain is separate and mind is separate. The problems that people usually face is because the mind is affected more. That is what you're trying to sort out more as compared to brain affected, which is more DSM-4 categorization that you talk about. Okay. So, and that optimizes physiology, behavior as well as health. Okay. The homeostatic and circadian processes regulate the propensity for wakefulness and sleep. So when you talk about, you are talking about two basic mechanisms here. One is homeostatic and other is the circadian rhythm pattern. So homeostatic mechanism plays a very important role because sleep is a method of homeostasis. That is where you are basically trying to maintain. But of course, as Malik sir had told in his class, that only 10% of his energy is actually restored during sleep. But rest of the time, you are actually trying to manage your homeostatic mechanisms, healing, and everything is taking place during that particular time. So it is basically a management and a balance in between the homeostatic as well as the circadian system. So within each level of analysis, sleep can be further characterized along multiple dimensions such as quantity, quality, and timing. So again, we are being repetitive here. Till yesterday, we were talking about quality and quantity. Now, when you look at it, I have added the word timing there also. So we are going to look into one additional thing, which is timing, which means it is also an important area. Because otherwise, what happens? If I tell you that you have to sleep for 6 hours, you can sleep at 2 o'clock in the night and add 6 hours to it, which might mean 9:30, 10. Right, because it's only the number of hours which need to be completed, that means. So that is why the timing is also additional factor that we have put in now when eventually we are trying to define sleep health. Any problems till now? Everybody okay? Okay. So conceptual model of sleep health when you talk about, okay, so there are going to be these 4 factors which are going to play a role. In this, a lot of people, when I eventually talk about disparities, okay, we'll talk about disparity when I go there. Let's talk about sleep dimensions first. So, according to Busey et al., they had identified these 5 things which were supposed to be the basic dimensions of sleep health. Okay? The first one is satisfaction. Then you have alertness, which is A. Then you have timing, which is T. Then you have efficiency and D. They call it sated. A scale is also developed which is known as Are You Sated, which is trying to measure the sleep health. There are only 3 scales till now which talk about sleep health in the way you want it to be defined or that I want it to be defined. There are only 3 scales which are talking about. One of them is Are You Sated? Okay, and one is Sleep Health Index, which is developed by National Sleep Society of America, but that is, I try to find it, but I think that scale is not easily available, or it is a paid scale or something. That's NHI I think is not available otherwise. So there are 2 scales which are used for a concept of understanding sleep health. So we'll talk about each one of them eventually in the next slide, but I would also want you to look at the sleep dimensions. These sleep dimensions are controlled by genetic factors, epigenetic factors, both of them. It is not only genetic or nor is it only epigenetic. Okay, so it is said that a number of times, if the parents are more predisposed towards being owls, the children are also more predisposed toward being owls. But again, I would say, I'm being repetitive, it is behavioral. That means it can be modified. Then second thing is molecular and cellular processes. So by saying that, we are also trying to quantify all these sleep dimensions. If it is controlled by genetic, epigenetic, molecular and cellular processes, all these 4 processes are measurable. They all are measurable dimensions, right? So that means sleep dimensions should also be measurable. If it is measurable, it is reproducible. Right? If it is measurable, it is going to be reproducible because I can give you a number, I can give you a value there. Right? So that is why the sleep dimensions of the sleep health is actually, when I talk about it in the next slide, they all are measurable dimensions. Then we go to system level processes. System level processes, you talk about the other things which are going to play a role. For example, inflammation, sympathetic nervous system, hormonal responses and neural activity responses. These are how these systems going to work. They're going to work based on these mechanisms, and then you are looking at its effect on health, disease and function. Anybody okay with this picture? Okay. Then proposed definitions, what all definitions were given by Bussy et al. And there are a few groups which have been working on it. So sleep health is multidimensional partner, as I said just now. Sleep equivalence adapted to individual, social, and environmental demands that promotes physical and mental well-being. So now another term here has been added, which is adapted. So that basically means the pattern needs to be adapted to or modified according to the individual, social, and environmental demands. Okay? If suppose there is someone who lives in, if you go to a Mumbai chawl, there is a one room where the entire family and the children and the grandchildren and the grandparents, everybody is living in that one single room, right? And they're able to sleep. Some of you might be having your individual rooms. The moment a cousin comes and mother tells you to share the room, you have a lot of problem because you think you will not be able to sleep. So this is an environmental demand placed over you. You are able to modify it, right? Similarly, when you talk about a thing like a social area, social changes, social structures which are going to be different, and individualistic preferences. Like some people are there who can sleep wherever you tell them to sleep without any hassle at all. Whereas some of them would want their own bed, their own pillow, their own sheet. How cleaned up? I have to wash my feet before I go to sleep. I have to clean my bed. I need a new bed sheet over my bed before I go to sleep. Others would not mind. Christina showed you a picture yesterday. The person is sleeping there, right? So good sleep health is basically characterized by subjective satisfaction, appropriate timing, adequate definition, high efficiency, and sustained alertness. So now we've put adjectives here beside everything that we were talking about. Earlier we were only talking about satisfaction, timing, duration, efficiency, and waking hours. Now we have put terms over there to explain them. What do you mean by good? That good is defined now. Okay, so here it would mean a subjective amount of satisfaction should be there. I personally should be satisfied, not you. I am sleeping, I have to be satisfied. Okay, then timing has to be appropriate, duration has to be adequate, that is within the range according to the age that you're talking about. Efficiency should be higher, usually more than 85% of efficiency is what you're looking for, and alertness should be there during waking hours. You do not need to be 100% awake during waking hours. There is bound to be different amount of propensities which are going to be there. So based on the propensity, based on the situation, you would expect yourself to be fairly awake. That is why we are using the word alertness during waking hours. Of course, when I'm driving, I'm not supposed to be sleeping, right? I'm not supposed to be sleeping during that time. If there's a red light, I would not sleep at that point of time. But after a heavy lunch, if you're feeling sleepy, I can tell you to go take a walk through. Students here who have attended my class, they know most of the times in the 145 plus, she's smiling. How many times do I have to tell the students, go wash your face and come? Other teachers might tell them to go out of the class. I don't do that. I tell them, go wash your face and come. So that means you were sleeping. Okay, so because that is an understandable thing, that after you have had your lunch or you have had a leisure period in the middle, you would want to take some rest, and the lectures become static, and the propensity to sleep is more in a theory class as compared to a practical class, of course. So the definition recognizes the sleep health is being best understood in the context of individual, social, and environmental demands. That is, a good sleep health may not look the same in every situation and for every individual. So the problem which came with the definition of health is not there now. Okay, because you have made it individual according to situation. So everybody's definition of sleep health would be different. So everybody can be normal, immaterial of the characteristics being different. Okay? Everybody okay? The last line I want you to read once again and see if it is clear or not. If you are able to understand it or not. Okay? Everybody okay with it? Okay? Okay, so now the stated concept that we talked about. So satisfaction, subjective, which is measured by subjective sleep quality. Then you have alertness, which is ability to stay awake and to stay attentive. It is also important that awake and attentive are two different terms. You might be awake, but you might not be attentive. Okay? So that necessarily is not the definition of, I would say, sleep health. What I mean by alertness here is you are able to respond to a situation. So for example, if I ask a question, I would expect you to answer, right? Because you are supposed to be alert in this particular situation. But if you're sitting and thinking like that, and I ask you a question, that's okay. You were maybe not alert, but that doesn't mean that you did not sleep very well. You were alert because you were sitting here. Alertness is also related to paying attention. This is not what alertness we are talking about here. Alertness and paying attention are two different things. If, for example, we have an earthquake suddenly, you will be able to move out. That is alertness. Okay, na? So alertness is not necessarily paying attention. You should be able to differentiate. You understand that difference? Everybody? Okay, alertness and paying attention is okay? Okay. So then timing, the sleep placement in a 24-hour cycle, efficiency, proportion of times that you sleep in the bed, duration, the total sleep time. Okay. That is the basic concept of SATED, and SATED is how you are measuring sleep health as of now. Because the concept itself was developed by UC et al. They are coming up with their own concept. Maybe after 20 years this could change. I am not saying that this is the fixed concept, but according to the authors who are the ones who have coined the term, this is how it is going to proceed. So first thing, what are the indicators? Why should they be the ones? The first thing is they should be associated with a health outcome. Anything which you are trying to define should be associated with a health outcome, because you are using the word sleep health over there. So the outcome has to be there. So albeit with some different outcomes for each dimension would become having a different health outcome, but each one of them is associated with a health outcome. For example, satisfaction. Alertness is going to decrease if the satisfaction is not there. You would feel uneasy during the day. It would be difficult for you to pay attention to anything, even though you want to pay attention to. So that is how a difference that is going to be there. Second, they can be expressed in positive terms. This is very important, because that was the basic difference that we're looking at in the WHO definition of health. It was more negatively worded as compared to a positively worded, because the moment you say the word complete, it becomes negative according to me, because complete is a paradigm. Complete is a myth. There is nothing called complete. There is nothing which is complete. So it is a total myth which is going to be there. So that is a more negatively worded. So here you're talking about positive terms more. So that also means there would be someone who is going to be having a good sleep health according to the standard or the values that you are talking about. Third most important dimension can be measured across self-report, behavior. It is measurable. Each component that we talked about is measurable, because you need to be able to measure the things to be able to explain the things, right? So that is why all of them should be measurable. Finally, each dimension has a good face validity and ecological validity. Of course, you're talking about validity and reliability, what we spoke about yesterday. So this is the scale. Are you sated? So the original questionnaire contains 5 questions, each related. This I think we put there. The scale is there. Are you sated is there in the booklet? I think it is not there. You can look for it. It was not available freely, but the students, some of them have done our study, so we do have a scale. If you want a copy of that, you can ask Iram or Jenny about it. They would be able to provide it to you. So the original questionnaire consists of 5 questions, each related to the frequency of meeting one dimension of sleep health. Each item varies from 0 to 2. 0 means never, and 2 means rarely, 1 means sometimes. And the total score ranges from 0 to 10 points, 0 being the minimum, and the 10 means the best one that you have. And the final total is done by adding everything together. So this is the questionnaire which is there. You want a copy of it, or you can just click a picture if you want. So satisfaction, you're talking about it in the terms of measured over here. Then you have alertness. Do you stay awake all day without dozing off? Acha, what is the meaning of dozing and sleeping? They are two different things. Dozing means you are sitting and you are dozing off. Napping is going to the bed with a prepared intention of going to sleep. That is napping. That is not dozing off. Dozing off basically means when the intention to sleep was not there. And napping means there was an intention to sleep. Okay. Then are you asleep for or trying to sleep between 2 a.m. to 4 a.m.? That question can be looked at in two manners. One is you are trying to go to sleep at 2 o'clock, you did not sleep before that, or you awake at that particular point of time. Because most of the patients who are coming to you in the clinic with poor sleep are going to say that they wake up in the middle of the night, which is usually in between these times, between 2 to 4, 2 to 3. That is the time they would usually want suddenly wake up. Then do you spend less than 30 minutes awake in the night? This includes the time that taken to fall asleep or awakenings from the sleep. Duration, do you sleep between 8 hours to the day, and roughly speaking about that. Total of all the items range from 0 to 10, with 0 means sloop health and 10 means good health. The final score is going to be defined by that. So this scale is called argusated. So now, having looked at that, now let's talk a little bit about the research. So sleep health intervention, this was a good article. You can have a look at a very thick article, but most of it is tables. So if you want to ignore the tables, you can ignore the tables. But it's a good article to read. It's an umbrella review. So when we say, do you understand an umbrella review? A review of meta-analysis itself. A review done, all the meta-analysis is known as an umbrella review. So they talked about these interventions which have shown to be effective in promoting sleep health. So now after defining sleep health, we are trying now to find out the interventions by virtue of which you can improve the sleep health. Because remember the first slide that I said you have to come up with strategies and policies to improve the concept also if you're talking about it. There has to be a statement which tells you how are you going to work on it. So sleep education, there were 17 studies which were quoted by this particular review, and while these reviews showed increase in sleep related knowledge, this was not accompanied by a change in sleep related behavior or sleep quality or duration, okay, which is unlike the expectations. You would want someone to be able to sleep better because you have explained it to them the importance of sleep. But a drawback in this particular aspect of it can be because most of the studies which were done on adolescents and on school going children. Most of the studies. So maybe that was a drawback of the study. Maybe that is why they didn't get the result. With some sleep education interventions demonstrated small positive impact on sleep duration or quality, the results were quite mixed over there. The second is a behavioral change method, most commonly used in infant children, supposed to be one of the most effective methods. There you must have seen children around you, infants around you who are awake in the whole night and sleep during the day. Mothers are totally hassled and then elderly tells them don't worry, they will learn. So that learning is behavior. So when I was immediately after I got married, I went to Germany for 2 years or so. My daughter was around 1 year or so at that particular point of time. And according to my Indian standards, I was very happy. I used to put her to bed by 9 o'clock. When I went to Germany, I realized children sleep at 6 o'clock. So everybody told me that my daughter has ADHD. She was diagnosed as ADHD when we went to Germany because she was moving around and she was fully awake between 6 to 9, whereas their children were fast in beds. And the children used to not even get up in the night. So if the parents had to go for dinner, the children were at home sleeping and the parents were out for dinner. And for us, unimaginable that you leave a 1-year-old child at home alone. And so that is how the differences are also there. So infants and children, one of the behavioral methods at what you teach them, that even though they are crying, they are yelling, they are doing whatever, you put them to bed at a certain time. Then you are trying to associate certain behaviors with sleeping. For example, brushing your teeth, wearing your pajamas, reading a book. Those things are associated with sleeping. So then what happens? As a result of it, the brain also understands, okay, that this process is coming, so I am going to sleep now. The same thing holds true for you also. That a lot of you would be not to be able to sleep in your regular clothes. You need to wear your night dresses to sleep. Right? You need to brush your teeth before you go to sleep. So a lot of these things are what you have inherited from what was taught to you earlier when you were a child. So standardized bedtimes, scheduled awakenings, positive routines. What is the meaning of a positive routine? Positive parenting is the buzzword these days. What do you mean by positive parent? Positive routine basically means you are not going to yell or shout on them if they don't have a positive routine, but they would be rewarded if they are having a positive behavior. मेरे ख्याल से तो बच्चे बदतमीज हो जाते हैं, उनको ना मारो तो, but अभी तो यही चल रहा है कि हाथ मत लगाओ, ठीक है ना? So the positive thing, you have to give them a reward if they're talking about something nicer. Okay, so don't hit them, don't shout on them. Mine gets scolded even now when she's 22, but that's a part. Sorry, I can't change. Yesterday only she told me that you yell too much. I said it's okay, ignore. Okay, so that, you are talking about positive routines, controlled and comforting environments, and gradual extension. That is, parents leave children alone for extended periods, ignoring protests as cries also. Okay, so overall, there is a substantial evidence that BCM in infants and children managed by parents most of the times is very effective and has shown an improvement in the sleep quality as well as duration. There is also encouraging but more limited evidence for other populations. Okay, so but that is what a lot of times CBT is working on. It's again a behavioral method, but again we are talking about CBT separately also. Then relaxation. Relaxation is what I think Krishna also spoke out to you about yesterday in detail. This is one area where most of us are working. Tarushi is not here today, but one of our PhD scholars, she worked on improving the, so she basically tried to change the behavior by teaching relaxation techniques to the subjects who were having poor sleep, and she found some positive results after the relaxation. So the strongest evidence in this category was for listening to relaxing music, supported by a meta-analysis also. Okay. Third is physical exercise intervention. There were loads of studies on physical exercises, loads and loads of studies available on physical exercises. We started way back in 1920s and are going on even now. And the reason behind that is, according to my understanding, is that because exercise in itself is not fixed. Every day one new exercise is coming up. When I was studying, concurrent exercise training was not there. But now everybody is talking about concurrent exercise training. We used to talk a lot about aerobic exercises in those days. Now it is anaerobic exercises which is the focus point right now. So there is so much of a change in exercise physiology that we are learning over the times, that this is something which is not fixed. That is why this is one intervention which is the most tried intervention as far as the sleep propensity is concerned. So physical exercise interventions have shown promising improvements in duration and quality, but the sample sizes in these reviews were mostly smaller, and the population-based work needs to be done more. Then aromatherapy or massage, again some evidence is available, and a lot of time you would see the people who are working on Reiki and alternative therapies more, and Tai Chi and all that, they have promoted aromatherapy and massage quite a lot, and there some of them have shown good results also. Then we come to mind-body exercises. Mind-body exercises basically are the ones where you talk about things like yoga and Tai Chi, where you talk about a collaboration between that, the mind, the so-called mindset, psychological mind, needs to be in association or in tandem with the body, then only the effects are going to be better. So controlling the meditation techniques and all that is going to be covered here, and they have shown mixed result, more towards leaning towards the positive side, I would say. Then sleep health disparity. Health disparity already is existing. आपको पता है कि अगर आप if you go to AIMS, most of you would not want to go to AIMS unless you don't have a contact there, right? You would not prefer to go to AIMS. You would prefer to go to Max or Holy Family or Escorts nearby. But why is that difference there? The difference should not be there. That means there's a disparity in the services there. Okay, so sleep health disparity is a difference in one or more dimensions of sleep health, either regularity, quality, alertness, timing, or efficiency and duration, on a consistent basis that adversely affects designated disadvantaged population. Okay, just read through this definition first and then I'll talk about it. There are some keywords here. I want you to read it, then I talk about it. Okay, you read through it? Okay. So what is the key term according to me here is the disadvantaged population. A disadvantaged population is the socio-ecological disadvantaged population. Okay, socio-ecological disadvantaged population. So that is why sleep disparity is also a socio-ecological parameter, or there is a model by which you can explain the disparity, which is a socio-ecological model which is there. Some of you might not agree with this, because I think I also at certain points might not agree with this. For example, when I say that a rickshaw puller should be able to sleep well according to our understandings. That is what even the PC sir was telling us, that someone who's tired or is exhausted should be able to sleep well. But according to this concept, it might not be very good, because they are at a disadvantage right now. So in a Mumbai Chawl room where there are 10 people, 15 people in a room, they are at a disadvantaged position as far as the environment is concerned. So there, if the person is coming to you with a sleep problem, they should be more addressed to as compared to someone who has an individual room and an air condition to sleep in. That is what disadvantage is all about. So health disparity is a health difference that adversely affects a defined disadvantaged population based on one or more health outcomes. So you're talking about higher incidence or prevalence of disease, including early onset or more aggressive progressions. Now studies are also showing that the disadvantaged population has more anxiety and depression, which was not the case earlier. Earlier you used to say na ki the rickshawala sleeps the best. They are the ones who are not bothered about it. they are the ones who are earning every day and spending every day, and they are okay with it. But the reason behind that was they are not a focus of research. No one wants to work on them because that is not getting the money. It's as simple as that. It is not getting the money. Now there are a few studies which are being conducted, like women, for example, where women were supposed to be a socially disadvantaged population, and a lot of studies, if you read research in the early 1900s research, 1910, 20, women studies are not there. There's a boom in women studies when after menopause got recognized, because that is the time pharma market came into picture. That is the time suddenly the women articles which you read would only be obs and gynae. Women health was supposed to be obs and gynae. A lot of people in the villages, if you go to, or if the smaller towns or lower middle class strata, according to them, women need to go to the doctor, to a female doctor. What is a female doctor? Female doctor is a gynecologist. That is the only health aspect which is covered on. So that is why women are also considered to be in a disadvantaged section. So a lot of studies on sleep health in sleep are not there as far as the women are concerned. So women and sleep, if you want to correlate, what you find is studies in menopause, that what are the changes which are happening in the body. Then you would be finding some studies related to postpartum depression, some studies which would be there, postpartum anxiety which is there, then depression, anxiety, then cancer survivors, breast cancer survivors. Those are the areas where you would be finding women studies more. Other than others, when you talk about athletes, 99% of them are done on males. So when the studies done are also lesser, of course, the health disparity is going to be there. Then premature and excessive mortality from specific populations, greater global impact of disease such as disability adjusted life as measured by population health metrics, poorer health behavior and clinical outcomes related to all these, and worse outcomes or validated self-report matters are there. Okay, so that is what health disparity is all about. So I'll just talk about this concept very briefly about what is the disparity. Again, I would say everybody doesn't need to agree with it. You can have your own point of view. Some of you might not agree with this model because this is a developing model. It's a very new thing in the market right now. It will be modified eventually as changes happen, as a society, and moreover, models like this keep on evolving because the society is in an ever evolving structure. So the model would also evolve. So first of all is an individual which is going to play a role. So individual health and well-being becomes important. For example, OSA is an individual thing. OSA is something which is very, very individualistic. Insomnia is not individual. Insomnia might be related to multiple other factors which are there, but OSA is something which is going to be more individualistic. Then you talk about race and ethnicity. You see Caucasians are supposed to be having better sleep as compared to blacks. The research is showing that. I'm not saying it on papers or just I'm not building it up. The research is showing that the communities of blacks in US are having worse sleep as compared to the whites who are there. Then immigration and refugee status. You think people in Gaza would be sleeping good right now? I don't think so. So when you are talking about differences there, those things also need to be kept in mind. Then discriminations which are there. Then you are having things like temperament, then biology, genes, and mental health. All these things are the second level of the family that you're talking about. Then we come to your family factors which all are there. When you talk about individual factors, what is also important is an individual factor is why mental health is mentioned there is because everybody's individual mental health is individual as well as family. Both are playing a role there. Because for example, there are a family of 5 with 3 children and 2 adults. Out of these 3 children who are living in a similar so-called environment would not be responding to it similarly. That is why you have an individual mental health as well as a family mental health. It would be talked about separately. Then family, you're talking about beliefs about sleep and health. The lights are out at a certain duration of time, or there are children at different age groups. Someone is having an exam, there's a 1 bedroom. So someone is studying, someone is covering their face with a sheet and trying to sleep because the exam is not there. So those are the things that you're talking about here. Then you're talking about resources, number of beddings which are there. There are guests at home, so you have to put your bedding down. So you have shifted in your room. Then household chaos, how much is the level of chaos which is there? Mother has to get up early in the morning. Cooker, she has put the cooker on the gas and it's whistling and you are trying to sleep. All right. Your brother is newly married and there is a small baby in the house. So, all these things are going to make a difference in the family atmosphere. Then neighborhood. Neighborhood में one of the very important thing which come is what kind of a location that you are looking at. Congested houses. Congested houses आपके घर में तो सुकून है मगर साथ वाले घर में सीटी बज रही है. So things like that are going to make a difference. So that is briefly about socio-ecological model. I'm not putting a lot of emphasis on it. I'm running. God, I'm very slow. I need to run now. Okay, so potential solutions that we're talking about, I want you to look at the changes here, and what can be done is mentioned in the second group, and the third column talks about the proposed interventions which can be taken. For example, language and cultural barriers which are there, the lack of sleep specific resources. When I was growing up, I was not told by my parents to not to study in the night. अच्छा बच्चा पढ़ रहा है, was happy enough. Now I don't want my daughter to do that. I tell her to no need रात हो गई सो जाओ before, especially before the exam. I make sure that she has to sleep. She might not want to sleep, but she has to go to sleep, especially before the exam. But I don't think my parents ever told me to sleep. They left us on whatever way you find better, you do it. Right? Whatever way you find better. Then lack of specific resources which are there, then beliefs about sleep health, procedure, perceived discrimination which is bound to be there, racism and bias. So all these things in the front you look at are the proposed things which can be done. So again, advocacy becomes important. Policies need to be in place. Then neighborhood proximity to green spaces, improved urban planning. You would want the things to be more greener, you would want the airs to be better, you want the pollution to be lesser. So just how the broad changes which can be talked about. Another important article here was prioritizing sleep health, public recommendations which were given. This is a good article written by Barnes and Ray. They have come up with certain solutions and policy examples here. One of the important things that they talk about was in adolescent. If you look at it carefully, most of you have finished with college or in college. Your classes usually start at 8:30 to 9. Right? Whereas in school, you were getting up at 7:30 school. There are schools in Delhi which are functioning at 7 a.m. also. So you are actually forcing the child to, you are not allowing the child to have a regular system of sleep. I am not questioning that either. Maybe then the children needed to sleep earlier and get up earlier. They could have maintained that if the college was similar. But that is not the case. So the school timing is one of the important points of discussion, especially in the West, not in India per se, but in the West it's a very important discussion which is happening around. The school schedules undermine sleep. Work schedules undermine sleep. The shift workers, they're working in the night. You want the officers to be functioning in the night. The guards need to be awake in the night. The doctors who are on the 48-hour or 24-hour or night duty need to be awake in the night. These days I've heard physiotherapists also need to be awake in the night because there are certain hospitals which are asking for night duties from physios also. So based on all that, the expectations from various professions are different. And the problem comes more, I think, in work schedules is one where you are not having a sustained schedule. So it is not that every day you are awake in the night. 1 month you are awake in the night, other month you are awake in the afternoon. So the body has a lot of difficulty in adjusting to those changes then. Then day saving policy according to these, you are familiar with the day saving policy? In Europe, and what they do is they decrease 1 hour when the winters come. ठीक है, तो उसकी वजह से क्या होता है कि आपका वर्किंग आवर्स जो होते हैं वो चेंज हो जाते हैं. योर बॉडी circadian clock is not changing, but the number of hours is changing because they're trying to work on saving the daylight because the sun sets much earlier. So basically they're starting the day earlier when the winters are there. Okay, so that kind of a system is not very acceptable system to a number of them. Then poor access to education regarding sleep, and poor access to treatment for sleep disorders. In India especially, the problem is that a psychiatrist is dealing with sleep disorder, and going to a psychiatrist is a taboo even now. I still remember there was a student who was according to me having quite a lot of depression. I talked to their parents and I told them to go and take the child to a psychiatrist so that some intervention can be done. They got really offended that how dare you tell me to take my child to a psychiatrist. And this is about an educated set of parents who are staying in Delhi, which is a privilege, I would say, would be exposed to a number of things. So the going to a psychiatrist is not something acceptable even in today's time. You might think that because we are talking about it openly, that it is acceptable. Sorry to say, it is not acceptable even now. So the access to sleep disorders is very, and moreover it is not identified, especially for elderly. Elderly, you are expecting them to sleep poorer. A lot of people would expect the elderly to sleep poorer. And elderly themselves also expect themselves to sleep poorer. So areas of disparity, you are looking at insufficient sleep and quality is going to be there. Then there is sleep apnea, which is going to be different in all, and pediatric sleep patterns are going to be different. These are the areas of disparity. Research strategies, I think I'm just going to skip this because I am running out of time. Then we talk about sleep hygiene. So that is the one part. Everybody okay with sleep health now? Are you able to understand the concept now? Everybody okay? Any problems, any doubts, anything which you want to ask me? Yes, please. Hmm. Hmm. Yes, 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 absolutely. See, as physios, but we also understand that when we are talking about assessment, socio-demographic is extremely important, and we as physios are putting it in the identification data. We are not assessing it down below. Before history, we're talking about the social history. That means as a profession in itself, we play a lot of emphasis on that. And that is the same thing how you would expect to be placing on this also. ये कहाँ है? पक्का ना? मारिए बाहर लेकर आओ. अंदर तो नहीं है ना? अच्छा फिर ठीक है. Okay, anything else? हाँ. Not all, either or. Hmm. Either one of them. Yes, yes. The disorder is not, a dysfunction is not only one factor. It is either or. It is at least one of the factor, one or more of the factors should be affected. Okay, now let's talk about. अरे ये क्या हुआ? एक second. Okay, so sleep hygiene. Sleep hygiene is just a set of behavioral tools which are there. A set of rules which are made to modify the behavior is sleep hygiene. What is hygiene? Cleanliness. So having a better pattern to sleep or having a clean sleep is sleep hygiene was all about. So this term was coined by Peter Horry in 1977, and he basically developed. There is no documented thing कि ये sleep hygiene है. Everybody has come up with their own thing. So there is nothing right, there is nothing wrong. Okay, that is the first thing which you need to understand. That sleep hygiene is not a scale, it is not an index. Sleep hygiene index is a method of measuring sleep hygiene, but sleep hygiene in itself is not, it's a concept more than a set of rules. Okay, so he came up with his own rules, and these rules have been considered for basic sleep hygiene methods over the times. More recently, it has been found that Paulo Menticozzo, who came up with this idea earlier than Peter Horry. But father of sleep hygiene is supposed to be Peter Horry, and Peter Horry itself actually talked about sleep hygiene because according to him, he did not get a better term than that. So he just coined the term randomly. It is not that a lot of thinking went into it, because he could not get a better term than that he coined the term of sleep hygiene. So these are basically a set of rules how to sleep better at night, and these rules target lifestyle, environmental factors that can influence the sleep. The best treatment for known improvement in sleep is this. As I told you yesterday also, that sleep hygiene is one strategy which you can apply for all your patients, and it is bound to give you result. There is no mixed reviews regarding this. Of course, if you're talking about a diagnosed sleep disorder according to DSM-4 guidelines, there the pattern is going to be different. There it is going to be one of the adjunct features. But for a regular patient with a dysfunction, you can use it as one of the treatment strategies also. So sleep hygiene may be conceptualized as practices which are relating to sleep routine, stimulus control, health, environmental, and cognitive and affective variables. Let's talk about each one of them first of all. So first we talk about a routine. The body understands routine. As physios, as medical professionals, you need to understand this very well. Body understands only routine. It does not like it if the routine is not followed. Simple. There is no discussion over this. So if you are used to sleeping at 9:30 in the night, you have to sleep at 9:30 in the night, immaterial of your social gatherings, immaterial of it being a weekend, immaterial of your exam going on, because the body doesn't understand anything other than that. That is how you train your body also. That is how you train your body also, that by following a routine. So when you are talking about your strategies for patient compliance, What do you tell the patient? For a change to become permanent, it has to be followed for minimum 3 weeks. It's a basic technique for patients where you're looking at a poor compliance for exercises. You tell them that follow it for 3 weeks. The fourth week would become easier. And the most difficult week is basically the second week. So that is the same thing which holds true here also, that when you're talking about a strategy, the body understands routine. Fix to a routine, stick to a routine. Before reaching that bedtime also, there are certain steps which you do every day. Those steps are a part of the routine because that is how your body understands. Remember that Pavlov's experiment where the bell rang and the food was given and salivation took place. That is how the body works. It's a simple conditioning method. That is how the body works. It would appreciate your core body temperature would start falling down the moment you start doing your process for changes. Second term here is stimulus control. Even if you are in bed, but you have a stimulus, you will not be able to sleep. That stimulus can be a noise coming from the air conditioner. The stimulus can be a switched on TV. The stimulus can be light which is coming from under your closed door because someone else in your house is still studying. Or of course the mobile and the social media, whatever, the blue light which is being emitted by your phone and tablets and the television. All these are the stimuluses. As Christina also told you yesterday, the bed is a sacred place and should be associated with a single activity. Because that is how conditioning of the brain takes place. Because you are associating the bed with a single factor, so a single factor change is going to be there. Then comes your health. If you're unwell, if you're having a headache, it will be difficult to sleep. So those factors need to be controlled. Then environment, we've talked about it. Cool, hot, too hot, wearing socks, all these things are there. Then cognitive and affective variables, how excited you are just before going to bed. For example, you have your exam the next day and you've taken out 5 hours that I need to sleep for this 5 hours. It will be very difficult. You'll have a very poor sleep efficiency that day because your mind is already occupied with the things. So cognitively you are more active at that point of time, or you were stressed because of some other thing, or something happened just before you were going to sleep, or you have had a stressful day. Okay. So sleep hygiene may be described as practices again, as I said, to facilitate sleep and avoiding behavior. So these are the two definitions given by two different people. The Maston group is one which has done a lot of work on sleep hygiene, and they have their own set of rules and a number of studies. The various populations they have studied. One of the group which has worked extensively on sleep hygiene is the first definition which has been given there. Now, these are the precipitating factors to a poor sleep hygiene. There are two kinds of factors. One would be lifestyle, one is environment. Environment is small, lifestyle is huge. So why is that the case? Because you are talking about sleep hygiene as a behavior practice. Behavior would be a response to the lifestyle. Okay? Behavior would always be a response to the lifestyle. Of course, if I'm going in a train and I'm trying to sleep, it is going to be difficult because the environment is not the same. But the problem arises when I'm not able to sleep on my bed, in my room, when there is no other environmental factor which is developing. It is troubling me. That is what sleep dysfunction is all about. You don't come, your patient doesn't tell you that I'm not able to sleep well and I slept in the train yesterday night and I didn't sleep very well. Is that a problem? No, that is not going to be a problem. Because you know that environmental factors are going to be different and those cannot be modified. The modification that you're looking for is from the lifestyle factors. Lifestyle means, now, when I come to the next, we are almost done. So when we are coming to the other factors which are there, the other thing which you're trying, as I said, there are no set rules. So what has been done, various studies have been conducted, meta-analysis has been conducted, and people have identified which are the factors which are most studied in sleep hygiene. That is how the rules are also formed, that most studied factors are basically the ones. So these are listed usually, I think, in the order of most studied factors. So caffeine is the most studied factor. What is the effect of caffeine before, of consumption of caffeine before going to sleep, or 2 hours before going to sleep, or 3 hours before going to sleep? This is one of the most studied on factor. Then alcohol, then nicotine, then you have dietary intake. Dietary intake, again, we talk about in sleep hygiene. That all these factors are the ones which have been talked about in sleep hygiene. That how much time difference should be there in between your sleep and your food intake. That's why you would see that a lot of people who are on a diet would not want to see and eat anything after sunset. No food after sunset is a very normal statement given by dietitians these days. Okay. Then you have anxiety and stresses. Then you have your stressed life events. Okay, anxiety and stress and stressful life events are two different things. Anxiety and stress is individual. Life event is more family and society and culture. Okay, so a stressful life event and you are feeling stressed because of a stressful life event is not individual. For example, there's a death in the family. You are bound to be stressful because of that. If you are not stressed because of that, that might be a problem. That you are, people would say that you are apathetic. Right? So life event is another thing and individual anxiety and depression is another thing. That's why they've being mentioned separately. Then irregular sleep wake timings, daytime naps, intensive training and competitions, travel fatigue, jet lag, and social and academic family environment and all that. So these are the things which are most commonly talked about in sleep schedule. First thing that you talk about is duration. That you need to go to bed between 6 to 8 hours or 7 to 9 hours, whichever idea you agree with more. Schedule has to be fixed. You talk about going to bed at a particular time, waking up at a particular time, immaterial of the surroundings, the environment, the other changes which are there. Exercise should be done. If you exercise well, the studies have shown that increased physical activity status leads to better sleep. There are studies which have shown exercises done till 2 hours prior to bed have shown good results, but there is a small body of evidence which is also showing that exercises done just prior to sleeping have affected the sleep quality. A small body of evidence is there for regarding that also. So I would prefer to tell my patients not to exercise too much, at least 1 or 2 hours before. So there is a trend these days where young people go to gym in the night because they're working during the day, they would want to go to the gym in the night. That, according to me, would be a little deleterious as far as sleep is concerned. If you're able to manage it, great. But otherwise, try to decrease that and have some kind of a difference in between the two. And by talking about this, I am not talking about a regular walk which is recommended after your dinner, because that is supposed to be at a self-controlled pace. That is supposed to be at a self-controlled slow walk. It is not supposed to be a brisk walk which is usually advocated for early in the morning. There's a difference in between the two things that we talk. Then weight loss, especially for patients with OSA, weight loss is very important because obesity is directly related to patients are suffering from obstructive sleep apneas. Other than that, obesity is also shown to be related to a number of other sleep disorders. Napping in the afternoon, okay, napping is good. It is promoted. In Spain, by law, the shops are closed in the afternoon because there's a time given for siesta. There's a siesta time there. You're not supposed to. You can actually, the police can come and catch you if they find you making noise during those hours. That law is there in Spain. So, but again, it is not supposed to be a long hour napping. It is supposed to be a short half an hour to 45 minutes nap which you take, not a 3-hour nap from 2 to 5 in the afternoon after a heavy lunch. Okay. Then light exposure, especially the blue light exposure, has to be restricted. The sunlight exposure has to be given. The people who are in their offices the whole day, do not leave their offices at all and are not exposed to sunlight at all, are supposed to be having poorer sleep as compared to people who are able to have some amount of exposure of the sunlight. Caffeine consumption has to be controlled. Caffeine again is not promoted by anyone other than sports therapists, where again they are giving caffeine shots to improve the performance. But other than that, caffeine is not supported by anyone. Whatever the studies might say कि black coffee पीने से और heart disease कम होते हैं and all that, these are all outliers. They are not falling in the center part of the study. Most of them are not promoting caffeine consumption at all. Then alcohol consumption not promoted at all. It is understood that, and I will talk about it, that a lot of people think that if you are very tired and you have a shot of alcohol, your sleep is going to be better. No, losing consciousness is not the same as sleeping. It is not the same thing. In fact, alcohol consumption decreases the propensity of sleep. So after a glass of alcohol, the sleep would be delayed and the quality of sleep is going to be compromised. Then we talk about eating before sleeping. At least 2 hour difference should be there in between the sleep and the dinner. So you should have your dinner, and that is why it is advised that there should not be any midnight snacking. Midnight snacking has to be fully avoided, because midnight snacking leads to when you're awake in the night, There is a hormone called ghrelin which is released in the body, and ghrelin is a marker, is a satiety marker. So basically, whenever ghrelin is released, you feel more hungry. So that is why you would realize when you are studying in the night, you feel hungry and then you eat, which would tend to lead to obesity then later on. Then eating before sleeping, then practice mindfulness, relaxation techniques, lie in your bed, think about good things, think about good thoughts, that works well. And a bedtime environment, side of the bed, softer bed sheet, temperature control, all these things are luxuries according to me. Only 1% of the population can control the environment, rest everything is controllable, but environment is just 1% of the elite population can control the environment. Others, the rest 99% of the world is not able to complete this environment. So this is something which you can modify, but because of course the patients who can afford us means they have some money, so you can advise them, that means they can control their environments. Is everything okay here? Okay. So these are the few tips which can be given to the patients. Aim to sleep between 7 to 9 hours of sleep. Have a consistent sleep time. Exercise regularly. Avoid late afternoon, evening naps and long naps. Avoid light exposure of electronics near bedtime. Limit caffeine consumption in the afternoon and evening. Limit alcohol consumption. Avoid large mixed meals and unhealthy food near bedtime. Practice mindfulness techniques. Create a dark and a cool, quiet sleeping environment. Have a consistent bedtime routine. Refrain from the bed from non-sleep activities and use comfortable mattress and below in bedding. This is one of the most commonly used set of instructions which are given to improve the patient's sleep hygiene. Sleep hygiene, this is again a very good article which talked about a bibliographic review. So I've put in a graph there. If you have a look at the graph, you can see it. Can I move the Acha cursor visible? See, these are the areas which have been found to be sleep hygiene component, which was supposed to be most effective in bringing about a result. And here you see caffeine is on the top. So most of the studies talked about caffeine. Then they talked about sleep restriction, which basically means decreasing the amount of napping. Even if you did not sleep in the night, do not sleep in the day. Then only you will be able to sleep in the night. Then they talked about alcohol. Then they talked about exercise, food intake, sleep timing, light, napping, noise, stimulus control, smoking, stress. Noise, I think, especially becomes a behavioral thing which was taught at the time when the child was born. A lot of children respond to noise more because they were kept in a completely silent environment when they were younger. So these days, pediatrician they tell you to not to stop the activities of the house when the child is sleeping, so that they get used to some amount of noise in the environment. So then there is stress, wind down routine, sleep medication, and comfortable bedding. Okay. Now another graph here that you see is some of the studies which have been conducted on these and what were the results. So most of the studies which we talked about were either two kinds of studies. One were observational studies and one are the longitudinal studies or interventional studies. So observational studies looked at the various behaviors. So first, what do you do and how is your sleep? Second, it was intervention was given and how is the sleep? That is how it was identified. So most of the things that were trying to control were eating before bed, if you see regularly, going to bed hungry, okay, drinking before bed, going to bed thirsty, drinking a glass of milk, eating breakfast, and maintaining a particular diet. These were a good set of ideas about diet which were talked about. Okay, so if you look at it carefully, it is important to look at the first component here. Eating before bed, how much time difference should be there is one of the most studied on factor as far as the diet is concerned. So precipitating factors for poor sleep are unique to individuals. We've already talked about it, that everybody is going to behave differently. And one of the important studies which was done by, this was a good study. Salient feature, contrary to expectations, they reported that women with insomnia actually used less amount of caffeine and alcohol per day and had smaller variations in day-to-day variations as compared to women who had normal sleep. Okay. So this study is an outlier, you can say, but that is what they concluded on. Sleep precision approach. Okay, this is important because why we talk these days, medicine is also moving towards precision. Now, you are familiar with that idea that everybody's drugs are going to be different. How much mg you need will be different. It is going towards more precision. So sleep hygiene again is a precision thing. So you ask the patient about their routine and you advise accordingly. You don't give them the handout. You don't give them the handout. Okay, you ask them the problems, you identify the features, and you develop a sleep hygiene practice for these patients. So that is why the sleep hygiene practice should be individualistic. Now, most of the studies, just a little bit about the clinical conditions. So, most of the studies in insomnia have focused on stimulus control therapy, sleep restriction therapy, CBT, and the CBT one has shown to improve sleep onset, efficiency, as well as duration. Second set of condition is depression and anxiety disorders. Here also sleep hygiene studies have been done extensively, and here what has shown a good effect is okay. This is especially good when you're talking about these young adults. When you see the college students, most of your age group people that you are seeing these days with the sleep dysfunction, which are very commonly associated with aches and pains during the exam period. So in our clinic also we would see that the number of students coming into the clinic is going to increase during exams. And you would assume that because they're sitting for longer times, that is why they are having the pain. That you're sitting for long because of the exam, you're sitting and you're not getting up. So you tell them to go take a walk in between that, have a glass of water in the middle, but you fail to ask them about the sleeping routine. And you would find that most of them do not sleep well in the night. That is why their aches and pains are much more, because the pain perception increases because of that. Okay. So establish a regular wake cycle, use mindfulness and journaling, which becomes second important factor. Avoid social media, and CBT again has shown good results. Adolescents maintain consistent sleep and wake routine. This is the primary for. See, the order in which it is mentioned is the order in which it has been researched upon and has shown effective. Okay. So here the most important thing is sleep and wake timings have shown to be most effective in young adults and adolescents. Then limiting caffeine and screen exposure in the evening. Educate about sleep importance. This population is one where education and advocacy is extremely important, because they take life as a part and parcel. Abhi kar lenge, baad mein theek ho jayega. I will modify it later. I will work on it better later. But they don't understand that the impact that the sleep is having on their health right now, some of them would be irreversible. Then Wheaton et al. Did a good study where they started school later times, and it was linked to a better sleep and academic success for the students. Then another study done by Gardner et al. They talked about reducing the screen time, and they found a lot of improvement in sleep as well as mood of the children. Then chronic pain conditions. Here again, here what is more important is decreasing the perception of pain. So that is why guided imagery becomes important just before sleeping. Progressive muscle relaxation. Then you're talking about maintain a comfortable sleep environment and tailor to the pain management which you're already talking about. Limit the daytime naps. Then CBT again showed good results, and as well as your behavioral interventions of bringing about a change and modification also brought about a good result. Older adults, again, it is understood that they should be having poor sleep according to us, and that is what they've been taught. They have assumed themselves that my sleep is going to be poorer because I'm older now. So once the body that you means, you can tell them, you can actually assume that they have conditioned themselves through that phenomena. Okay. So avoid long daytime naps, establishing calming and predictable bedtime routines. And according to a study done by McCarry et al., again, light and behavioral therapy brought about a good amount of change. And according to Fung et al., environmental modification brought about a good amount of change. Then these are SP's 5 good principles: value, prioritize, personalize, trust, and protect. This is what your sleep hygiene practice should be focused on, because this will vary according to your patients. So for value, you can find something else for patient A and it would be something else for the patient B. Similarly, prioritizing times for a student, maybe studying is a priority. For someone who's working on the laptop, maybe using the blue light is not a choice, it's a compulsion. Someone who's a night shift worker, it is a compulsion, you cannot modify that. So the variation has to be done. That's why I said there is no set sleep hygiene practice. It has to be modified according to the individual. Then you talk about personalization, then you talk about trust issues, and you talk about the protection. So these are the basic 5 principles that you're going to advise in good sleep. So summary of the clinical strategies. Sleep hygiene practices can be practiced across clinical population. It is not focused on any one single group. everybody should be taught. As a clinician, you should be teaching it to all your patients. CBT1 is foundational for insomnia and chronic conditions, because there you're looking at more behavioral modifications. So CBT plays a good amount of role there. Then daily routines, screen time restrictions, light exposures are important, and behavioral interventions improve both sleep as well as other conditions. So assessment, now we talk about, there is a good assessment method which is known as SHI, which sleep hygiene index, which talks about the measurement of the sleep hygiene practices. It gives you basically a score. As predicted, the strongly related to sleep quality and moderately related to perception of daytime sleepiness. And the good part about this index is that you can actually use this index to give you a value which should improve or decrease based on the intervention that you have given. Chronotype. This was a good study which I just wanted to speak to you about, that everybody that you are saying that if you are an owl or a lark, you are supposed to be in a certain time. But there was a study which was conducted which found that evening chronotype was associated with a decline in academic performance in the high school. When they went to college, it declined even further. But when they were modified, when they were behavioral changes and they were converted from night owls to clerks in the last year, they showed an improvement in the grades. So that shows two things, that A, it is modifiable, B, it can be related to the other things also. So sleep hygiene specific population, students, manage screen time and routines. Shift workers, sleep environment and light exposures become important. Elderly, consistent routine and reduced napping. These are the three factors with specific populations when you are dealing with. Myths working fast, everyone needs 8 hours. I've talked about no, everybody doesn't need 8 hours. Alcohol helps in sleeping. Alcohol doesn't help in sleeping. It actually brings about a decreased quality of sleep. It brings about, rotates more in REM. Non-REM quantity decreases as well because of alcohol consumption, and losing consciousness because of excessive alcoholism is not going to sleep. I can catch up on weekends. No, sleep debt is there. Sleep debt can be covered a little bit on weekends. I'm not saying you cannot, but the effects of debt cannot be covered up completely. I can, snoring is harmless. No, snoring is never harmless. It means it is associated with an underlying pathology which needs to be diagnosed. Watching TV scrolling helps to relax. No, it increases your level of excitation. Blue light is associated with increased wakefulness. It will not lead to relaxation, which is associated with sleepiness. And napping is always good. No, napping for a certain duration is good, but more than a certain duration of time would lead to a decreased sleep in the night. Older adults need less sleep. No, it is not that. It is not the case. They would need good amount of sleep. Again, they might be a little lesser, but according to the geriatric studies, they need again 7 to 8 hours of sleep is needed by elderly also. So building your sleep plan, if you want to bring about a change in the people around you, if you want to change the patient population that you are dealing with, you need to bring about a change in yourself also. So as physios, we should exercise, we should maintain our health. Similarly, if you're talking about a sleep physio, you want to become, at least work on that particular area, there are certain things that you need to bring about in your system also. At least start with 2 to 3 changes which you can bring about. Track the results for 2 weeks, because again, 2 week itch is it's actually there. If you're able to maintain it for 2 weeks, third week would be easier and fourth week would be a pattern. And adjust as needed and stay consistent with whatever you're talking about. So quick self-check, do you actually feel refreshed? Feel sleepy within 30 minutes of getting up? Wake up more than once in the night? Or do you consider maintaining a sleep time, if that is the case? What habit would you like to bring about a change from starting tonight? Just think about it. You can also discuss with your patients like that, and after you've spoken about everything, you can reflect with them and sit down and tell them that, okay, this is what I've taught you. Tell me what you're going to change today. There are certain things which are short-term goals. There are certain things which are long-term goals. So short-term goal means what can be brought about today. Write down it and commit for it for 1 week, and let's review it after 1 week. So like that, you can bring about smaller changes in the behavior in the patient. That's all. Okay. Any questions do you have? Any questions? Thank you. Huh. Loads of studies are there on night shift worker. Sana came up with a proposal at her PhD because she wanted to work on nurses who work in the night with a rotating shift. Most of the studies that you see are there on shift workers only. So there's extensive literature available on them, and there are different set of strategies which are used for managing the patients with the poor sleep in this set of population also. Anything else? So snoring is associated with one of the factors of OSA. It is associated with OSA also, and it basically, yes, those patients should be checked. Those patients should definitely be checked that why is the snoring there, because you're not supposed to be snoring at all. It is not that amount is more, less, noise is less, more. Those things are immaterial. Snoring is not normal. So you need to identify that and you need to be assessed, and that needs to be checked. That is not a pattern. That is not a pattern. That is not a pattern that you are looking at. But sometimes snoring also, I would not think that it is okay, because even if you are tired and exhausted, your pharynx and larynx need to be opened up. So that means there's some underlying pathology which is exhibiting itself only when you are tired. So that is, it is not normal to have it, but I would say that it doesn't require immediate intervention. Immediately I don't need to work on it, but you should be working on it, because it might lead to a problem later on. It might get converted into another condition later on. So assessment should be done. Yes. Hmm. No, snoring itself is a sleep disturbance. No, that is what I'm telling you. That is what it is, a myth. That sleep, that snoring is a separate thing, and sleep quality and quantity is a separate thing. No, snoring is a part of sleep quality and quantity. If you are snoring, that means one of the aspect of sleep is inappropriate. Huh? Huh? Sleep is not a single component of sleeping in the night by quality and quantity only. Sleep is also associated with snoring being a negative factor which is affecting. So that what you are selling is that sleep quality and quantity are two separate things, and a regular sleep is something else. No, all three are together. For you to be having a totally healthy sleep, quality, quantity, and other aspects have to be restricted. So even if you're telling me that if a patient is snoring but is able to sleep 8 hours, I am fine in the morning because I'm able to sleep 8 hours. No. Snoring itself is a pathological condition which needs to be worked on. Yes. No, no sleep apnea, period. No sleep apnea. No sleep apnea, zero. Sleep apnea is not a part of the normal physiology of sleep. Anything else? Okay, thank you. ये मेरा नहीं है, मेरा फोन कहाँ है? ये तुम्हारा है, अच्छा.
Thank you so much, Professor Zubia Vakar ma'am, for breaking down the core concepts of sleep health and sleep hygiene and offering such valuable and applicable insights. It's clear how essential these strategies are for both practitioners and patients. It's time now for a short break. Please refresh yourselves, take your coupons along, and be back by 11:50 a.m. Thank you.
The thing is right outside.